So I want to welcome everybody to Fetal Boards. We're going to go ahead and get started this morning. Dr. John Buchholz, our third-year resident, is obviously presenting this morning on fetal pyelectasis. We'll get started.
Okay, welcome everybody. Thanks for coming. Like Dr. Cooper said, my name is John Buchholz. For the students that don't know me, I'm a third-year resident. Today we're going to talk about fetal pyelectasis. So just kind of an overview. We're going to start with the case presentation. We're going to kind of go talk about a patient we selected that had fetal pyelectasis, go through some images of that patient, discuss the history, discuss the antepartum course, the postpartum course. We're going to kind of talk about the ultrasound diagnosis of pyelectasis, and then move on to antepartum management and postpartum management, kind of what we do when we do find this condition. So to start the case presentation, patient is and was Miss W.A. She presented as a 23-year-old G2P0010. She initiated care at University Health at 16 weeks, 1 day. She was a transfer, I believe, from California. She had a past medical history of migraines. She previously was on Topamax, had stopped that when she found out she was pregnant. They were well controlled. She had no past surgical history. She, at time of initiation, was only on prenatal vitamins, had no allergies, no contributory social history. Family history, she did have a nephew with Down syndrome. She also had consanguinity. Her husband was her third cousin. And like I said, this is her second pregnancy. Her first pregnancy was a SAB at 5 weeks. She passed it spontaneously. There was no DNC. And then GYN, she denied any history of abnormal pap smears or STDs. So on physical exam, really nothing truly significant. Thyroid was normal. Breast exam was normal. Her abdomen was normal exam. Fundus was palpable, consistent with a 16-week pregnancy. Her pelvic exam was benign. So pretty much everything on physical exam was benign. So this was her first scan. This was her anatomy scan when she presented 7/29/15. This is 3 weeks after she had her first OB visit. At that time, she was 19 weeks and 4 days. Her growth was 74th percentile, so it was normal. At that time, they did the anatomy survey, typically done between 18 and 22 weeks for the students. She showed mild bilateral pyelectasis and a mildly echogenic bowel. The lateral ventricles were normal, but there was a space between the choroid plexus and the medial wall of one lateral ventricle. So the plan at that time was a follow-up exam. Fetal heart and face exam were limited at that time by fetal position. Okay. So this is the first imaging at the time she presented. So this is image of the renal system. Right side at the top, left side at the top. You can see there's a bilateral hydronephrosis, more significant on the left than on the right. It was measuring 8.1 millimeters on the left and 4.2 millimeters on the right. Depending on the guidelines, over 4 centimeters is sometimes diagnosis pyelectasis. So this, from criteria, would meet diagnosis on the right and on the left. Also, those arrows indicate where you see the echogenic bowel. Is there anything else you wanted to add right now, Dr. Brett?
Well, the 2 arrows on the right are the bones in the spine. So when the bowel is as echogenic as bone, or is as wide as bone, it's considered echogenic. If it's not as wide as bone, then by definition it's not echogenic, although some people do have gradations between mild, moderate, and severe. And Dr. Cardinal, I think, did that fetal boards back in the fall about echogenic bowel.
So at this time, what was the management plan with this patient? Patient was offered amniocentesis. She declined. She did desire and accepted non-invasive prenatal testing. And for students who aren't familiar with this, it's a blood draw. It can be done after 10 weeks. You draw maternal blood looking for fetal cells that are in maternal circulation. And it detects for trisomy 13, 18, 21, and also determines the sex chromosome. Because of the echogenic bowel, she also had cystic fibrosis mutation testing, and then CMV and toxo titers were ordered. At that time, she also had got a quad screen in her initial presentation. That came back within normal limits. The levels of all four were appropriate for gestational age. Her non-invasive prenatal testing came back 46 chromosomes, XY.
That's incorrect. It doesn't say how many chromosomes.
Okay.
It only looks at 13, 18, 21, X and Y.
So sorry, normal 13, 18, 21, and XY. And then her toxo titers were negative. Her CMV titers were positive for IgG, and IgM was negative. So if you guys remember, IgG indicates probably a past infection. She didn't seem to have any acute infection. And her cystic fibrosis screening was negative for, I believe, 97 different mutations. So we had her back on the 1st of September. She was scanned again. She was 24 weeks at this point. Again, growth was appropriate. At this time, it had a normal review. The lateral ventricles were now normal. Bowel was now normal, and kidneys were normal. This was discussed with the patient. Plan at this time was to repeat the CMV titers since she had a positive IgG, and then follow up ultrasounds in 2 months to monitor growth and relook at anatomy. So there's an image of the left. It's now 0.44. It's 4.4 millimeters and 2.6 on the left. Sure. She's 24 weeks. So as we talk later, as the gestational age changes, kind of what the upper limits of normal is changes too. In November, we rescanned her. This is now approximately 8 weeks later. She's now 32 weeks and 2 days. Growth was again appropriate. It's declining a little bit. It's 17th percent now. Bowel again was normal, but at this time the left kidney had mild hydronephrosis, actually extending up to the calyces. Calyces were dilated, and there was a dilated right renal pelvis, consistent with possible UPJ obstruction. Or sorry, the left was consistent with possible UPJ obstruction. The right at this time only had mild pyelectasis. So as we talk later, it's pyelectasis, hydronephrosis, in some literature is used interchangeably. Usually it tends to transition to hydronephrosis when you start to involve the calyces and you get dilation up there. So if you look now here on the left, you can see dilation at 7.8 millimeters. And if you look in the right image, you can start to see dilation of the calyces. Is there anything else you want to add to that, Dr. Brad? On the right, we're now 3.7 millimeters. Some mild hydronephrosis you can see on the left side. As you see on the right, the renal system itself appears normal. The calyces aren't dilated. So we've now followed up again. This is ultrasound the 8th of November. Growth has now dropped off. The AC is small, less than 10th percentile. She still had left-sided mild hydronephrosis, and again, probable UPJ obstruction. At this time, her AFI was 5. She was called oligo at this point. Her BPP was reassuring. Due to all these issues at this time, the decision was made to send the patient over for delivery so that pediatrics could be present for the delivery. This time you can see the images. Left renal, you see the dilation. Again, that upper right image, you're seeing dilation of the calyces again. And then the right, maybe some, were you calling that mild hydronephrosis at that point or resolved?
When you see the calyces, they're like little.
Yeah, those are on.
So basically, that's just the renal pelvis.
Yeah, right. So they're normal right there.
Yeah, so
And then
that's,
dilated up there.
yeah, the only lab has dilated calyces.
Okay. Okay. So this is a pediatric note after the delivery. I will tell you the patient came over on the 8th of December. She underwent routine induction of labor. There was no complications. Due to the possible UPJ obstruction, pediatrics was present for the delivery. Besides that, it was a very uneventful labor and delivery. Baby did well, mom did well. So due to the history of fetal pyelectasis, a renal ultrasound was ordered and was completed. And the fetal echogenic bowel, like we said, those CMV studies were positive in the past. IgM was negative ×2, and the toxo studies were negative. Cystic fibrosis testing was negative for 97 mutations. Of note on this patient, the baby did have an imperforate anus on examination. There was an anal dimple, and PED's initial note said they were unable to perform digital examination or they were unable to pass a thermometer too when they attempted that. So at this point, they obtained a general surgery consult on the infant. They called it possible low imperforate anus. The general surgery resident was initially unable to pass a thermometer, but with gentle pressure was able to pass it, and when that was done, liquid stool returned. At this time, there was a discussion of surgery versus dilation. At this time, they were going to manage with dilators and discuss with their staff. They kept the patient overnight, and due to this issue, they wanted a vectoral workup, which included a renal ultrasound, which we're already getting, cardiac echo, spine films, and an NG tube placement. So this was the renal ultrasound. We got this due to the hydronephrosis found during the antepartum pregnancy. So it was an ultrasound of bilateral kidneys. The right kidney measured 4 by 2.4, which was normal, and the left measured 4.5 by 1.9. They were called normal in size and echogenicity. They didn't see anything concerning. Now, there still was some mild pelvic ectasis of the left kidney they didn't see any frank hydronephrosis, and they didn't see anything on the right side. They didn't see any paranephritic fluid or definitive masses that'd be concerning for, and the bladder was normal appearing. So they called it imitable left-sided pelvic-tasis without frank hydronephrosis. They called it otherwise grossly normal renal ultrasound. So just to follow the end of this story, the baby had the imperforate anus. It was repaired with a limited posterior sagittal anal rectoplasty. There was concerns of a little bit of breakdown as of a month ago. Baby did well, didn't have to be reoperated on, and now it's getting intermittent dilation and will eventually go to no dilation. In terms of renal ultrasound, since the last one was so mild, at this time there's not one planned repeat for the PEDS notes. So that was our case presentation. Now we'll kind of go on to fetal pyelectasis and what that means. So the definition is dilation of the renal pelvis with or without dilation of the renal calyces. And like I said earlier, this is used interchangeably. Some people call it hydronephrosis once you've involved higher up in the renal system. Some studies just kind of use it interchangeably. So epidemiology, males versus females, tends to affect male infants twice as often as female infants. And bilateral versus unilateral. Bilateral tends to have more cases that require surgery, and it varies depending on the case study, 20 to 40%. Incidence, they give a pretty broad range of incidence, anywhere from 0.6 to 4.5% of pregnancies. And as we go through some of these studies, we'll talk about why it varies. The main reason being, when was it diagnosed, and what was the criteria for diagnosis of hydronephrosis, of pyelectasis. And one number we'll look at is 1.6. So Lee et al. Did a large meta-analysis of multiple studies and that was the overall incidence from their study. When you get this 4.5, this higher range number, it tends to be with a very strict criteria, which is becoming now the more accepted criteria for diagnosis. It's using the RPD, the renal pelvic diameter, greater than or equal to 4 millimeters, and that's based off a study as Molly et al. Did. So RPD or APD, same thing, renal pelvic diameter or anterior posterior diameter, they're used interchangeably in some of these papers. So if you classify it that way, they kind of look at it. So on the left, there's different cutoffs for second trimester and third trimester. Normal to be larger in size, obviously, as we go along in the pregnancy. And a lot of the studies, they'll differentiate from mild, moderate, severe, and severe. Severe is where they really start to be concerned. So a lot of these studies will talk about greater than 10 centimeter or 10 millimeters, greater than 15 millimeters in third trimester for when they really start to be concerned that there may be intervention needed. So there's 3 different grading systems, and I won't go into a great deal with them. RPD, that's the renal pelvic diameter. That's the most common one. The majority of all the studies use that. But since you have obstetric issues, pediatric issues, urological issues, everybody likes to kind of create their own grading system. So Society of Fetal Urology created a system too that uses a grade 0 to 4 system, and we'll show some images of that. And then one big recent study did a urinary tract dilation classification system. That was, I believe, joint between urology and pediatrics. And they again tried to classify things based upon antepartum, postpartum images, and severity. So like I said, RPD is the most accepted method. You're measuring the maximum anterior posterior diameter of the renal pelvis, and you're doing that in the transverse plane. And the issue with this, as we talked earlier, is where's the cutoff for normal? It tends to be 4 millimeters or greater, but this can be changed depending on what your sensitivity is. So this image isn't even as good as the ones we had previously, but this is just showing bilateral pyelectasis of approximately 4 millimeters.
I just want to go back to what
Yeah.
ones we had. It's important about how you measure. So when you measure it, you need a transverse of the abdomen at the level of the kidneys, and it's AP or PA. This is like the best because the spine is up and you have the kidneys on either side in the pararenal fossa. You don't want to measure transverse because that's going to be a real big measurement. So it's AP in the largest AP diameter. That's what you want. And then we just get the sagittal to look at the calyces. So you see those dilated calyces. And this one, no dilated calyces. So AP, that's important. If you don't have a straight AP image because of the direction of the spine, then it can be off a little bit. So that's just my only comment I'd make.
Okay.
You right here?
Yep.
Okay.
So there was that image. So this is Society of Fetal Urology. We'll just go through it very quick. Grade 0 is a normal examination. Grade 1, you start to have mild dilation of the renal pelvis. Grade 2, you start to use moderate dilation of the renal pelvis, and you start to include the calyces. Grade 3, you've now got dilation of the pelvis with visualization of all the calyces. And grade 4 is similar appearance, only difference is the renal parenchyma starts to thin. The only note they had was if you have thinning renal parenchyma before complete dilation, they still call it a grade 4. It upgrades to that at any point there's thinning of the renal parenchyma. So there's images starting from the left all the way to the right. You can see on the right it's pretty severe with that dilation, and the renal parenchyma on the right side of the image has really started to thin. So etiology, what causes this? The majority of this, we believe, is a transient dilation of a collecting system. But that's not what we're concerned about. That's not why we monitor that. If that's the cause, that's great. It resolves or it causes no significant issues. The things we're concerned about are upper lower urinary tract obstructive uropathy or a non-obstructive uropathy. The non-obstructive ones would be vesicoureteral reflux, megaureters, or things that are rare like prune belly. Most common causes, again, the number one most common cause is transient hydronephrosis, and that's looking at fetal pyelectasis as a whole. As you start to get more severe pyelectasis and hydronephrosis, some of these other causes jump up as the far more common outcome. So also ureteropelvic junction obstruction or vesicoureteral reflux. Transient hydronephrosis, again, depending on the case, it's 41 to 88% of cases. It probably tends to be, the lower number would be on some of these studies they've done where they've had a lot more significantly sick patients or more increased severe dilation. Since those tend to be included in the study, you tend to see more other outcomes besides the transient hydronephrosis. When you start to see the number around 88%, that's probably including some of the studies where they diagnose it really early, sometimes as early as 11 to 14 weeks on transvaginal ultrasound. The vast majority of those resolve, but if you include that in your numbers, you're going to see a higher percentage of caused by transient hydronephrosis. Again, transient hydronephrosis, studies have been done, and if you use a cutoff of an RPD less than 6 millimeters in the second trimester, it almost always tends to be transient hydronephrosis, and less than 8 millimeters in third trimester. Now we talked about we use a cutoff sometimes of 4 millimeters, so you kind of have those few in between that you're going to catch, and those are important to follow up. But typically as a population as a whole, they don't tend to have significant pathology. So you're worried about sometimes congenital anomalies of the kidney and the urinary tract. So this study was looking at antenatal hydronephrosis, and they used it as a predictor of postnatal outcome, and they did a meta-analysis. This was by Lee et al. They had 1,300 patients, and 36% of those patients had pathology discovered on postnatal evaluation. And we look at this, they included about 15 studies. And as we talked earlier, we had those images breaking down antenatal hydronephrosis, grading it from mild on the left to severe on the right. And they included studies that used a similar grading system, and they included them in their study. And as you see, when you look at more studies that include larger numbers of severe here, you start to see a lot more people that had postnatal pathology. So some of the mild cases did have pathology, but you really start to see that number increase as you get to the moderate, severe, and severe. So this, they broke it down. So overall, they looked at all their patients, and people who were diagnosed with mild antenatal hydronephrosis, only about 12% ended up having postnatal pathology. And that increases as you go to the right, all the way up to 88% of that severe. So you see that's 8 times increased risk with that. Now, when you look at what's the most common pathology, uteropelvic junction obstruction was the most common. That was 54% of the severes. So that's the most common in severe. Now, when you start to get to moderate severe, it actually, vesicouteral reflex tends to be more common. As you see, it tends to be 14%, 12% versus 8% of the severe. And the other were, ureteral obstruction wasn't statistically significant. So like we said, most common diagnosis, uteropelvic junction obstruction, and that does correlate with your degree. The more severe it is, the higher risk you have. Vesicouteral reflux is the second most common. That doesn't correlate with your degree of hydronephrosis. So again, other causes of congenital abnormalities of the kidney and urinary tract. We have megaureters that we talked about earlier, multicystic kidney, ureteral seals, ectopic ureter, prune belly syndrome, urachal cyst, duplex collecting system. We're not going to talk about any of these in depth, but they are other causes. Severity of hydronephrosis. So like we said, surgical risk and pathology risk increases with severity of persistent hydronephrosis. There's no criteria that identifies all cases in terms of measurement. If you create a threshold for measuring that's smaller, you're going to increase your sensitivity but decrease your specificity, versus having a higher threshold to diagnose somebody. And that's basic statistics. So also in the Lee Menal, this is just the numbers we talked about, that mild hydronephrosis, 12% had pathology, 45% of the moderate had, and when you get to that severe, 88% had pathology. And the next study we're going to look at is a postnatal longitudinal evaluation of children diagnosed with prenatal hydronephrosis. This was by Barbosa et al. So they looked at slightly more than 1,000 cases of pyelectasis. Of those, 25% resolved in the prenatal period. They had 742 remaining patients. 440 of those followed up for an actual postnatal exam. So they looked at what degree of hydronephrosis persisted at initial postnatal renal ultrasound. And they had a mean age of 3.5 months for that first ultrasound. It varies. If you're not concerned about severe, usually it can be done 1 to 3 months out. 80% of the mild, 88% of the moderate, and 95% of the severe persisted at that imaging. Now, they also looked at final follow-up, and on average that was about almost 21 months. It can vary anywhere between 18 to 2 years, depending on your concern. They had persistence in 10% of the mild, 25% of the moderate, and 72% of the severe. So as you see, the mild, moderate, almost all of it, majority drops off by almost 2 years out, but that severe hydronephrosis can persist up to 20 weeks or even longer. So this is just what we talked about, severity and surgery. This looked at surgery rates too. Mild hydronephrosis, 10% of those required surgery in the postnatal period, 24% of the moderate, 13 of the severe required surgery. Again, we're just harping on this point. The more severe it gets, the more likely you are for complications, for surgery, for need for follow-up. Timing of the ultrasound to detect fetal pyelectasis. It's most commonly detected during routine ultrasonography. This tends to be 18 to 22 weeks because that's when we tend to do our anatomy scans. And when it's diagnosed, we typically repeat our imaging during the third trimester, usually early third trimester, somewhere between 28 to 34 weeks. This is another study. This is prenatal anterior posterior pelvic diameter cutoffs for postnatal referrals. So for isolated pyelectasis and hydronephrosis. So this is looking at patients, when it's diagnosed, which of these patients need a referral, especially a urology referral. And this was by Bassanese et al. They looked at 149 cases and case studies. Everybody had to have ultrasounds at 20 and approximately 20, 30 weeks postnatally at 1, 6, and 12 months. They used a threshold of less than 6 millimeters at 20 weeks and 10 millimeters at 30 weeks. So under that, if you were under 6 millimeters at 20 weeks, under 10 millimeters at 30 weeks, in their study of these 149 patients, that ruled out obstructive uropathy, surgical intervention. So they were again arguing if you use that cutoff, the majority of cases you won't have any underlying obstructive uropathy or people that need surgery. Prenatal diagnosis and management of mild fetal pyelectasis. This was a Signori et al. Case. They looked at 280 infants. They had infants who had 2 prenatal ultrasounds, typically an anatomy scan and a third trimester scan. And also they had to receive a complete postnatal urological evaluation. Again, people they're concerned with if on that repeat scan on the third trimester, the dilation either increased or persists, that was predictive of surgery. Again, resolution of dilation tended to exclude them, and this is the numbers they looked at. So they had 51 cases who their third trimester ultrasound, they had complete resolution. It resolved, it went back to normal limits. 51 cases, 1 out of those 51 required surgery, 2%. You had reduced dilation, 97 cases, 3 of those, so 3% required surgery. Again, the vast majority didn't need any surgical management. Those that didn't change, 86 cases, 7 of those required surgery, so we're increasing our percent up to 8% at this point. And increased dilation, RPD greater than 10, these are the ones we talked about, the other studies really worry about. 46 cases, 11 requiring surgery. So, Down syndrome. Pyelectasis itself is a common finding in a Down syndrome infant. When you define it as that kind of lowest sensitivity, RPD greater than or equal to 4 millimeters in second trimester, it's present in 18% of Down syndrome fetuses. So when you see that as an isolated finding, is it something, how do you screen those patients? Obviously you do a complete fetal survey at that point. If there's no other findings on fetal survey, the recommendation previously was quad screen. Now that cell-free DNA and non-invasive testing is becoming more available, it's something you can also offer to the patient as reasonable testing. If there's any additional anomalies noted or the NIPT comes back abnormal, you go back to diagnostic testing and offer the patient amniocentesis. So they looked at isolated fetal pyelectasis detected by transvaginal sonography in advanced maternal age patients. Garaglia et al. Did this. So they had 1,093 women who were undergoing amniocentesis. All these women were undergoing it just because of AMA. They had 56 women with pyelectasis at between 11 and 16 weeks, and all these patients received that was a transvaginal ultrasound. And then they followed them. They did an ultrasound at 16 to 18 weeks when they did an amnio, and also at 22 to 24 weeks, they again reevaluated them with ultrasound. As you see, 56 at 11, all the way, that resolved all the way down to 23 at 22 to 24 weeks. So more than 50% of those resolved on their own, just when we typically tend to see them between that 18 to 22 week scan. So when you look at some of these higher numbers, we talked earlier, these 4.5 or even greater percents, these might be from a lot of these studies where it was transvaginal diagnosis. Of these 1,000 women, they had 12 cases of chromosomal anomalies and 1,037 women without pyelectasis, 2 cases in the 56. Overall, this was not statistically significant. They did not see an increase with isolated pyelectasis. There's a lot. When I look for research papers, there's a whole lot of people who tried to do studies on this. There's a lot of smaller studies out there. So There was the isolated fetal pyelectasis, risk of Down syndrome meta-analysis by Dr. Groom's favorite other MFM, Dr. Bergala. There was 2,100 cases of isolated pyelectasis when you added all these cases together and excluded repeat studies or studies that were using data from multiple studies together. And they came up with a positive likelihood ratio of 2.78. They, in their meta-analysis, did not say in and of itself it increases your risk enough to make, they did not make that strong a statement. They did said they can use it, they see it using a risk modification to further calculate your risk.
So it depends on how old the patient is. So she's 18, her risk for Down syndrome is like 1 in 1,500. So it's not going to increase it that much. But if she's 35, then she's got a much higher prevalence, so that's a bigger finding than if you have a young one. So it really depends on what the baseline risk is to begin with.
So, like Dr. Briette said, if you have a higher baseline risk, they suggested you could possibly, you should counsel your patient on this possible risk and see what they want to do for testing. Ultrasound examination, what kind of things are we looking for? Obviously, the severity, I think I've hammered it in, the more severe it is, the more risk you have, and the persistence. If it tends to resolve, it tends to have better outcomes. Unilateral versus bilateral. Bilateral tends to have worse outcomes or more commonly associated with pathology. Bilateral is, again, about that 20 to 40% of cases. You want to look at the renal parenchyma. If that starts to thin, that's a concerning sign. You also always want to see if you see any findings in the ureter and the bladder. Amniotic fluid volume. Obviously, if a patient gets oligo or low fluid for the students, that's more a finding of abnormal urological concerns and concerns that would be concerning for obstruction or pathology. But on the other side, normal amniotic fluid volume does not mean you have a normal baby in a normal renal and urogenital system. Also looking for urinoma and urinary ascites. These are very rare. If you do have them, there's obviously something very concerning with the baby, especially concerning for obstruction. So we have image of the bladder. Lower left, you have fetal bladder, and then up on the right, you just have a dilated right kidney. And the left has some mild dilation too, right here. But that was just an image, so you can see what it looks like when you start to have more dilation. See the bladder in the image. Genetic counseling. We are very lucky here. We have Dr. Urson, who does a lot of genetic counseling for us. But it's important when you end up going out or if you end up somewhere else to get these patients genetic counseling when they have diagnoses like this. They specifically said it always should be offered if the patient has additional fetal anomalies, if the patient's AMA and has an abnormal quad screen. There's a whole lot of papers just discussing, I found just on the ethics of fetal pyelectasis, especially from pediatrics, of how much do you concern the mother, how much do you scare them, and finding the right balance between, yes, the majority of this, if it's mild, does go away, but we don't want to be so dismissive that they don't follow up, they don't get involved, and make sure they come back for their visits, especially here when we struggle with that. So follow-up ultrasound. We follow up that ultrasound in the 3rd trimester. Like I said, persistent hydronephrosis, greater than 10 millimeters or greater, those are concerning. A lot of guidelines recommend those people definitely need a postnatal evaluation by pediatrics, possibly by pediatric urology. Alternatives, they recommended there's a possibility if it's 2nd trimester between 4 to 7, you can do a postnatal ultrasound at 3 to 4 weeks if you want to follow it that way. Bilateral hydronephrosis, since that can be more concerning, some of the guidelines recommend serial ultrasounds every 2 to 3 weeks. That's plus or minus. I don't know what you tend to do, Dr. Briette, is that?
Depends on the severity.
Yeah. So like I talked about amniotic fluid earlier, oligohydramnios is the most reliable predictor of abnormal fetus renal function. Like I said, the absence of oligo does not ensure normal renal function. There was some studies that came out where some MFMs looked at studying the sodium and beta-2 microglobulin in fetal urine. They were doing it in the antepartum period, drawing it up, trying to assess what the renal function of the fetus is going to be. Can it be predictive? And they overall said it's not really done anymore. It's not clinically accurate in predicting what the fetus's postnatal function would be. few articles said they use it in select cases, but they didn't define what they chose as select cases. Fetal testing, they recommend NST or BPP twice weekly, beginning at 32 to 34 weeks, if there's associated oligohydramnios or was oligohydramnios with that patient. So planning for delivery, how do you manage these people when it comes time to deliver them? You have a tertiary care facility with pediatric urology that's only required if there's concern for severe obstruction. Patients that you're really worried have had persistence or increasing or really abnormal ultrasound findings, they probably need to be at a place with pediatric urology is available. If it was minimal or resolved, those can be delivered at most standard facilities. And again, cesarean delivery is reserved for obstetric indications. I feel we tend to know this really well as OB, but other services always tend to ask, well, are you gonna section this person? And there's no indication. Important, like we did with our case presentation, was notify pediatrics that you may have a complication, you may need them, so they're ready, they have things available, and they're aware of the fetus. So postnatal management, what do you do with the fetus after, well, I guess now the infant after they've delivered? Things you specifically want to look for, you want to look for an abdominal mass. That can be indicative of an obstructive uropathy or multicystic kidney. I also said palpable bladder in male. I guess that tends to be one of the cardinal signs of posterior urethral valves, which tends to affect males. Outer ear abnormalities. Pediatrics look at those when you have already a concern for abnormal anything of kidney or urinary tract. Outer ear abnormalities increase your risk of congenital kidney or urinary tract disorders. Single umbilical artery. I know a lot of us look at it because it has an increased risk of IUFD, but it also has an increased risk of renal anomalies, specifically vesicoureteral reflux. And then spinal or lower extremity abnormalities. If those are present, you have to really be careful if the infant has a neurogenic bladder. So postnatal ultrasound, when's the timing for this? It's generally avoided in the first 2 or 3 days after birth. But if there's severe bilateral hydronephrosis or those with severely hydronephrotic solitary kidney, they may need imaging because they may need immediate surgery. Typically, otherwise, in severe cases, it's done in 1 to 4 weeks after birth. If the ultrasound does not show mild cases or is concerning further findings, then they'll typically go to avoiding cystourethrogram. Specifically, it detects vesicoureteral reflux in males and females and evaluates that posterior urethra in males. So this is imaging avoiding cystourethrogram. The arrows on the bottom here show a dilated urethra, and then the arrowheads indicate a dilated ureter with vesicoureteral reflux. And diuretic renography. So this can diagnose urinary tract obstructions. Typically, they don't order it till after avoiding cystourethrogram is negative and you have a high suspicion. It uses isotope and shows renal function, and they image it. It can show you if you have an they also give furosemide and follow how the void, how much fluid's given. And then finally, MRI. Like most other fields, MRI is increasing in its diagnostic use and management use in any complication. They said it's especially helpful in some of these cases where they have difficulty diagnosing obstructed kidneys or obstructed kidneys with rotational anomalies to see the anatomy, see how it needs to be corrected. And antibiotic prophylaxis. So again, we're getting to pediatric things. Papers I read, there's some debate. Some of the experts recommend antibiotic prophylaxis for people with severe hydronephrosis. These kids tend to have increased UTIs and increased complications for that, so they tend to give them amoxicillin anywhere between 12 and 25 milligrams PO daily, and they continue that from birth until a diagnosis of vesicoureteral reflux or obstructive uropathy is excluded. I didn't see a lot of information on why people would discourage it. It may just be they don't think it's significant enough that it's worth the risk of antibiotics or that it clinically helps. So if you have a normal postnatal scan, that depends on how comfortable your pediatric urology is. It tends to be, though, if it completely resolved, you don't need any further evaluation, or if it's very mild, like in our patient's case, there tends to be no further evaluation beyond that. Mild to moderate, again, this tends to be more moderate, but some cases of mild, especially if there's concern, you can repeat it 3 months after the first one to follow up. And then finally, this is just a diagram I found that was pretty helpful. So if you use that 4 millimeters diagnosis, again, you get it at your anatomy scan. If it's bilateral, then you can kind of move farther down the chain. Do they have oligo? Again, oligo at 18 to 22 weeks is poor prognosis. You need to counsel your patient. If not oligo, serial repeat ultrasounds every 2 to 3 weeks in this. Again, if oligo presents at some point, you need further monitoring and management, which depends on your gestational age. And then if it increases greater than 10, these are the people you really worry that need a pediatric urology evaluation, or at least a pediatric evaluation, the ones you'd be more concerned about getting a scan within about 48 hours. Otherwise, if it's not bilateral, you can usually repeat at 3rd trimester. And again, if it persists, you use a postnatal evaluation. If it's not bilateral, this guidelines usually says somewhere approximately greater than 7 days, a week to a month out, you can evaluate them. These are the references, the multiple studies you guys heard me talk about a little bit from Creasy. And then I wanted to thank Dr. Briette for her help. She helped me select the patient and also helped edit my presentation. And does anybody have any questions?
I have a question.
Yes.
It's kind of more of a pediatric side, though, as far as, I didn't notice.
Okay. Look at us, we're obstetricians.
I know, I just, if he saw
Yeah.
in his
We
reading,
don't like pediatrics. Anybody here like pediatrics?
do they check the creatinine? Is it ever a problem at birth? I mean, as far as renal
The only
function?
few things I found were, they indicated a little bit, they can follow it, but usually they said things like sodium
So the
tended.
creatinine at birth is the mother's creatinine. I mean, so like a neonatal creatinine is basically useless.
Yeah,
I
that's,
mean, you're not gonna get a real creatinine, I think, for like maybe 4 to 5 days.
and that's what I can say. They said maybe some studies talked about studying sodium and some of
I mean,
the
that's
other
why if you have a
metabolites.
kid with, renal agenesis, you deliver a baby with renal agenesis and you get its serum right when it's born, it's gonna have a normal serum creatinine, because that's all Placenta did all that.
And that's, they talk about some of these real severe cases. That's why they evaluate them within 2 days, because they said by the time the point the renal function has started changing, it's usually irreversible at that point.
That's when they do the renogram with the isotope, that tells them more about function than I think a serum creatinine. And they only do that with severe cases. So,
Dr. Grum?
Yeah. Echo what Dr. Briette said, but in a nicer sort of way. We're all a bunch of obstetricians, so what message do you want to leave your fellow residents with today? One message. And I'd say, the more complicated, the more severe. Something a little bit more fatalistic.
Fatalistic?
Platoistic, a little bit more,
I don't know.
showing a little
it-
bit more insight than that.
I think the difficult thing is, Dr. Groom jokes you can sum this up in 30 seconds, and in some ways you can. And the problem is, what was a little frustrating to me, I read paper after paper and looked at this, and there's a lot of debate both ways. Everybody wants to suggest what is the best way to handle it, what they think's the best in their case and the cases they looked at. I think it's a good example of a lot of things in obstetrics we see. There is no right answer.
Okay, but look, the practical question,
Yeah.
practical questions is, you have a patient who's 35 years old and she's got isolated pelvic dilation. What's her risk of having a baby with Down syndrome?
So,
slightly higher.
I mean, you can if you use that relative risk, you can make it.
Well, how do you use the likelihood ratio that was given?
They said it's 2.158, so you can
No,
double
it's
it.
2.65.
Oh.
What's the risk in somebody who's 35 years old, 1 in 1?
24?
1 in 200.
265. So
Right,
even
so-
if that increased, you could say it went up to 100 and 1 in 110, 1 in 100.
1 in 100,
So,
okay?
which
So
is
that's
still
a
pretty
type-
low.
That's right. So that's the take-home
Yes, sir.
message. At least you can leave them with that.
But if you have somebody who's 21 years old and her risk is 1 in 1,500, it doesn't increase her risk very much.
No,
So
right.
it's a 1 in 750 or
That's
whatever,
correct.
so you don't have to get too excited about it.
No.
It's like, the younger people, if they have a quad screen, I think that's plenty. They don't need to have an expensive fetal DNA test.
No, but the point is,
So-
if you've got somebody who's 35, even then, and they're
Still not
dilated, it's
significant.
still just 1 in 100. So you can counsel your patient with a little bit of reinsurance before you send them for this great big ultrasound.
Yeah.
That's all.
Yes, sir.
So it's a low risk.
Yes, sir.
That's the take-home message.
So what we do is we just repeat it on third trimester. We screen them for either quad screen or NIPT, depending on their age. And then we'll just repeat our ultrasound in the third trimester. If they're still dilated, then we just let the pediatricians know. So now, those are the people that are mild to moderate. If they're more severe, then we look at those a little more often, particularly if the calyces are dilated.
Any other questions?
Go home. You got anything?
Okay, thanks, everybody.